We have another very hot debate اللي هو controversies in optimal medical therapy برضه. Should sodium glucose transport 2 inhibitors and ARNI now be considered first line treatments in HFrEF؟ يعني نبتدي بيهم first step ولا هنستنى نبتدي في traditional way of treating heart failure؟ فالبرو دكتور كريم محمود استاذ امراض القلب في القصر العيني، وعندنا الكونترا استاذ دكتور سيد فرج هو اللي ايه دكتور كريم اتفضل.
Thank you, my dear Professor Dr. Mahmoud Hassanein, for the kind invitation. My topic today is about defending that sodium glucose cotransporter 2 inhibitor and ARNI should now be considered the first line treatment in HFrEF patients. And to do that, I'll tell this presentation in 10 reasons why we should do that. Simply, number one, ARNI is good. This is based on the paradigm heart failure trial that showed the reduction of cardiovascular death and heart failure hospitalization by 20%, with the number needed to treat is only 21 patients. This was also was associated with a reduction of cardiovascular death, hospitalization for heart failure, and death for any cause. And the second cause, the SGLT2 inhibitors are also good. So if we look to DAPA heart failure trial, the dapagliflozin as compared to placebo showed a reduction of 26% of cardiovascular deaths and heart failure hospitalization, with number needed to treat is 21 patients. This also was associated with a reduction of heart failure hospitalization, a reduction of cardiovascular deaths, and the reduction of any cause death. Empagliflozin showed a similar reduction with a 25% reduction of the heart failure hospitalization and the cardiovascular deaths, with the number needed to treat is 19 patients in the EMBRA-reduced trial, and this was associated with a reduction of heart failure hospitalization. So we have two good categories of drug, ARNI and SGLT2 inhibitors. And both drugs are actually good together. One can postulate that the beneficial effect of SGLT2 inhibitor may be due to the introduction of ARNI into clinical practice. However, if we look to SGLT2 inhibitor trials, the use of ARNI was low in these trials. In the DAPA-HF, it's about 10%, and the EMBRA-reduced is about 18 to 20%. And this meta-analysis showed that SGLT2 inhibitor exert a beneficial effect whether ARNI was used or not. So both drugs are good together. And the fourth point, we now have data regarding the use of these drugs in acute heart failure. And we should start these drugs while the patient inside the hospital. In the Pioneer heart failure trial, the ARNI showed a reduction of NT-proBNP as compared to enalapril, and this was started from the first week. And this was also associated with a good clinical outcome, such as a reduction of rehospitalization for heart failure, and also a reduction of the composite of serious clinical events, which was this rehospitalization for heart failure, implantation of left ventricular assist device, or listing for heart transplantation. Regarding the SGLT2 inhibitor, we have some evidence from the subgroup analysis in the DAPA-HF and the EMBRA-reduced that the drugs were beneficial among hospitalized patients. This was shown in the DAPA-HF and EMBRA-reduced trial. And we have this pilot trial for empagliflozin in acute heart failure patient that showed a reduction of worsening of heart failure, death, or heart failure admission at 60 days. And of course, we still wait for the final result of this trial. And we have also a data from sotagliflozin, which is a new SGLT2 inhibitor and also SGLT1 inhibitor. It's a dual SGLT2 inhibitor that showed a reduction of cardiovascular death and heart failure hospitalization among the patient with worsening heart failure. So both drugs are good in acute heart failure. Another beneficial effect is the renal protection. And if we look to ARNI and this meta-analysis, ARNI compared to enalapril or ARB was associated with a reduction of renal dysfunction. And if we look to SGLT2 inhibitor, starting from the canagliflozin, that showed a reduction of both worsening renal function and death from cardiovascular and renal cause. And this was also associated with a reduction of renal adverse event. Also, the DABA-CKD with a GFR included patient up to lower to 25 milliliter per minute showed also a similar result with a reduction of worsening of renal function and death from cardiovascular and renal causes. And this was also associated with a reduction of renal outcome. In the EMBRA-reduced trial, the empagliflozin was associated with a lower reduction of GFR and lower renal event as compared to placebo. And this also the new sotagliflozin that used in a patient with CKD and diabetes mellitus, and it showed a reduction of cardiovascular death and heart failure hospitalization. So both drugs are good for renal protection. And it's very important to do that without doing harm. So what about the safety of these drugs? If we look to the ARNI, as was mentioned, the most consistent event is a symptomatic hypotension. And if we can appreciate the reduction of the blood pressure to less than 90 millimeter mercury was more in ARNI. However, if we look to the percentage of patient, it was only 2.7% as compared to 1.4% in enalapril. On the other hand, ARNI was associated with a lower increase in the serum creatinine, lower hyperkalemia, and lower incidence of cough as compared to enalapril. Regarding the dapagliflozin in DAPA-HF, there was no concern regarding the safety, and it was comparable to placebo. And the only adverse event that was significant in the EMBRA-reduced was increased incidence of uncomplicated genital infection with empagliflozin use. So a very important point is the cost. And the cost here should not be an obstacle to use these drugs, because these drugs are cost effective. If we look to ARNI, the ARNI as compared to ACE inhibitor was cost effective in multiple trials, not only in this trial. And this another trial that showed comparing the ARNI to ACE inhibitor and ARB, both showed a cost effectiveness of the ARNI. And this was a trial from the Canadian journal that showed that the de novo initiation of ARNI was the best strategy and the best cost-effective methods for preventing an event in patients with HFrEF. Similar data was showed in this trial in the JAMA Cardiology that showed that dapagliflozin is also cost-effective in patients with HFrEF. Given the evidence of clinical benefits and the economic value, focus should be on increasing therapy rates among patients with HFrEF with or without diabetes. And at the point, the early initiation of these drugs is better than late initiation. We have some clues from subgroup analysis in the 3 trials. And if you can appreciate, it's better, we have a better outcome with initiation of these drugs in patients with New York Heart Association Class 2 more than in the advanced heart failure. So to start this drug early would give a benefit for your patient. And we have now consensus and guidelines that say we can do that. If we look to the consensus that released from American College of Cardiology, recommend again to use RAS blocker together with beta blocker and diuretic as needed, and ARNI is preferred. And we have also multiple classes of drugs that can be used, such as mineralocorticoid receptor antagonist, diuretic if the patient need, hydralazine isosorbide mononitrate in patient with in the African patients, and ivabradine if the heart rate is still high despite the use of beta blocker. But we have also the SGLT2 inhibitor that should be used in patient with HFrEF if the GFR allows. And we should remember that ACE inhibitor or ARB should be considered in patient with contraindication, intolerance, or inaccessibility to ARNI. The Canadian guidelines come with a similar conclusion, and the standard therapy now for the Canadian guidelines is SGLT2 inhibitor, mineralocorticoid receptor antagonist, beta blocker, and the last ARNI. ACE inhibitor, if started, should be replaced by ARNI, and it's very important, as Dr. Mahmoud mentioned, to initiate this standard therapy as soon as possible and titrate it as rapidly as possible. And we have some release from the upcoming heart failure guidelines, European heart failure guidelines. All drugs are given a class 1 indication. The ARNI is giving a class 1B as a replacement, and we should not understand the replacement as a second-line therapy. Replacement doesn't mean a second-line therapy. It means that ACE inhibitor is good, but we can replace them with ARNI. And lastly, we have now the term 4 pillars. And the 4 pillars are ARNI, beta blocker, mineralocorticoid receptor antagonist, and sodium glucose cotransporter 2 inhibitors. All of these agents should be initiated in parallel and should be optimized and increased accordingly. And also we have, as mentioned, the term Fantastic Four that include ARNI, mineralocorticoid receptor antagonist, beta blocker, SGLT2 inhibitor, and ACE inhibitor ARB should be used if cost concern according to this paper. And I'd like to conclude with this statement that that was a conclusion of this very nice paper of 4 pillars. Moving forward, we must recognize heart failure for what it is. It's an incurable disease with a mortality rate similar to many forms of cancer, where any delays cost lives. Once we have done so, we need to implement pathways that offer rapid initiation and where required up titration of life-extending therapies. And thank you.